semi-centrifuge. But now we have a lot of laser centrifuge where you have automatic settings for each of the patients before we design on PR. Like just like any patient we can do. So basically you have to have the patient is very which is there, which when you focus, you can see the weight. Okay, so that it's going to, and always tell the patient to keep their fist closed. So generally the patient's fist is closed, automatically you can see the mild veins being projected. So that's sometimes so that it is easier to detect the vein. So can you see all the participants are able to test when you are going in, go slowly only and withdraw. Do it very slowly. Okay. So here you can see that the blood is. We always try to get 10 ml of blood. Okay, because the PRF will totally differ on each patient. So if you draw 10 ml, we are sure to get a good amount of PRF. So when a IPRF is again third generation of growth factors. So if you see the centrifugation level. சரி அப்ப எடுத்துங்க டக்குன்னு டைம் ஆச்சு. நீங்க போயிட்டு சக்கரை மூச்சமே வந்துருக்கு. Marking of 1, 2, 3, 4. So that depends on the centrifugation step. 1000. And generally the slower the speed, now the new concept is the growth factors are much more than the normal PRF. The IPRF has a versatile advantages if you see, because now we have started using IPRF along with bone graft. So we get what is known as sticky bone. Once we mix IPRF and put the bone graft together, it gets into a polymerization reaction, and then 10 to 15 minutes after we get what is known as a sticky bone. So that will be like more like a putty-like mass which we can condense into the defect. That is for IPRF. Other than that, it's used a lot because they are all non-surgical things. Initially, interdental papillary, we have to open, put a graft, close, very complicated. But IPRF, we have done studies. It's not only for regeneration, it can be used for healing as well as any kind of, as I told you now, collagen helps in collagen turnover. What study I told was done in our department. It's published also. So that is for interdental papillary regeneration. So IPRF, now they're using it for hair transplants. So any kind of area where they require a regeneration of collagen, metabolism. So many benefits are there. We have to convince for the patient. So if you see here, the basal layer is the, which one? Killer to the in this region, what is the main issue is we have to minimum keep about 10 ml of liquid only for IPRF so that we could get the proper IPRF. Whereas you have kept only 5 ml because I just want you to give a demo. So this male is on the liquid now, you can see it's very less. So the syringe it's not there. But if you take like 10 ml, we'll at least get like 2 ml of IPRF. So that can be withdrawn, and then as I told you, you can mix it with a bone graft or can be used for interdental papillary regeneration or any case we can use it. We are supposed to have more of growth factors. So initially we started with PRF, IPRF, now CGF. So in my practice also now mostly I try to do sticky bone combined with IPRF so that together it works as a periodontist combo. So we have also published papers where a lot of research we have done. First I started on PRF. We have published. Generally you have to cut the RBC layer because the RBC will take up and then you can clean. So if you see now we have got very less of PRF. One is because we have kept only 5 ml of. If it's a little more this thing, we can make it like a real flat membrane. So in the this can be, see, in the PRF this layer of the PRF which is getting attached to the RBC has the maximum amount of growth factor. So நம்ம கட் பண்ணும்போது எப்பவுமே ஒரு லேயர் ஆஃப் less of PRS. Arrange பண்ணிருக்கோம். Okay, we can go to the hands on. Then we will just use it. Okay, ma'am. Okay. So generally the armamentarium வந்து உங்களுக்கு வந்து you should have surely one universal curate at least, even if you don't have the entire set. As what are the other ornamentarium? Quadrangle is there, and especially posteriors now always better to have a longer one than the short handle. And idiyume adjust pandra mari there is a BP handle also. Okay. So you can make a guess if it's wrong, it's okay.
15 and 14.
So namalukku konjam easier ah irukum. Happen like this. So from that time I always try to put a tape here because that's like it could be become a life threatening one. So எப்பவுமே வந்து நீங்க BP blade போட்டுட்டு you're putting the blade, see to it first of all it's a thing like how you have it in the humans, but generally வந்து ideally வந்து you have to do a really edit பண்ண சொல்றோம். You might be thinking why should we have a hand screw? So only this grasp and rest will be there lifelong. Going to surely at some point of time cause some injury to the patient. So whenever doing any procedure, 100% don't do the rest. Even if it's a cavity cutting, not the rest. So this finger should always be the rest. So without the rest, you never have control. So keep the rest properly. This I am telling only non-surgical first. So curettage la வந்து நீங்க நல்ல deep pocket குள்ள போயிட்டு you have to remove the granulation tissue like this. Okay, so never the subgingival tooth surface, and you are going to do you are removing the subgingival calculus. At the same time, root planing strokes on the short overlapping and because you had to wait how much time? PGs enna sonanga PGs enna idu PGs la enna, but sirs telling no, even up to 3 months we have to wait. Ena inflammatory component totally subside ஆகும். So நம்ம வந்து பண்ணும்போது subgingival deep-ஆ போய் எடுக்கலனா granulation tissue inflammation, even now I am seeing patients still inflammation is there. Then we have to do one more sitting of preparation phase. Sir said no, what are the contraindication enna sonnaru? Bleeding, on probing, or if there is inflamed tissue, don't do it. Enna on the flap, what could you anticipate? Internal bevel incision கொடுக்குறீங்க. ஒன்று recession require PGs, you are expected to do a modified ligament for exam, but that is what the examiner will be happy about. But generally வந்து அதுக்கு ideal case இருந்தாலும் நம்ம பண்ண முடியும். So வந்து ஒரு recession இருக்கதோ decrease with the attachment பண்ணா we cannot go for a what flap modified ligament. So generally வந்து when you are going for a internal bevel, so இப்போ வந்து what you have how should the internal bevel incision be? See, this is see, suppose you are probing with a pocket. So you can see here, this is the pocket. So now when you are going to give the internal bevel incision, it should always be about 1 to 2 millimeters away from the gingival margin, and it should be parallel to the tooth. See, you cannot, you are going to do what? The internal bevel incision would purpose always go only parallel to the tooth, okay, and you have to follow the curvature of the, you see again you are going to, you can see here it is going around the tooth, then again you are going to go like this. So always the tooth for the parallel blade, and it should hit the bone, the internal bevel incision, because you are trying to remove what? The pocket lining. Okay, so if you see here, this is the internal bevel. We cannot follow the exact scalping like how you have in the gingiva, the humans, but kandipa on you have to follow the contour of the, see here, you can see no, I am having the, you have to follow the curvature of the gingiva. So you have this point to follow the incision. Once you are giving this and you are reflecting automatically on the layer of the contour. So then what you have to do is, you should always have a very good periosteal elevator. what you're using for extraction will not be useful for. I want that other one which is having a P24, one with a sharp end. So you should have good assistance so that its work is much more easier for you all. So generally PGs tissue reflect பண்ணும்போது என்ன பண்ணும்னா ரெண்டு பேப்ல சேர்ந்து தான் ரிஃப்ளெக்ட் பண்ணும். ஒரு பேப்ல மட்டும் பண்ணீங்கன்னா என்ன ஆகும்? There is a chance that it might tear. So நீங்க இப்படி புடிச்சிட்டீங்கன்னா ask your assistant and then you have to remove all the granulation tissue. இப்போ இது clean-ஆ இருக்கு இல்லைன்னா இங்க எல்லாமே உங்களுக்கு granulation tissue இருக்கு. So you are removing all the granulation tissue and also doing the root planing. And you can see why you have to remove the granulation tissue. After you can see any subgingival calculus. So then you remove all the subgingival calculus. So generally we have to fully do the curettage and then finally we have to see to it that if there is a defect, as I told you, we can do a bone grafting with PRF or modified ligament. To go for a conventional flap, we can directly proceed and give the. Go like this, give only the circular reflecting, and when you are on the periosteal you can அப்பவே நீங்க இது செப்பரேட் பண்ணுவீங்க. Okay, so when you see here, this is how. And generally if you want to coronally position, then if you are taking there's a mild restriction, now what you could do is you have to go beyond the mucogingival junction and accordingly we can elevate the flap. And suppose we are going to, that's why I said generally you are giving a vertical incision. Now you have to not, the papilla is here, you have to include the papilla, never dissect the papilla. So you have to give an incision like this and it should always go beyond the mucogingival junction so that only then we can coronally position the flap. So generally in practice it's very mandatory that you are having what to say, the basic surgical instruments like a good periosteal elevator is very mandatory. As I told you, even if you are not having the P24, you can have not, this is a bulkier one. I would prefer a smaller periosteal elevator. Maybe say this is another periosteal. You can see it's much more fine. So periosteal elevator sharp automatically easier reflect பண்ணிடுவாங்க tissue. Once you reflect, you are curating and then try to put the bone graft open. இல்லைன்னா என்ன பயங்கரமா bleeding இருக்கும். We will not be able to see anything and the patient also is going to be not happy about it. When you are doing a clean surgery, patient also gets more confidence in you. Okay? So if there is any doubt, you can ask me. So otherwise you can proceed to the hands-on. Okay? Blade கால்குலேட் பண்ணிருக்கீங்களா? இன்டர்னல் பேப்பரா? அப்ப அந்த லைனிங் இது போட்டிருக்கீங்களா? இதுவா? இது வந்து நீங்க ரொம்ப ஒரு லைனா தெரியும். ஏன்னா இந்த டிஷ்யூ கர்வச்சர் இல்லை, அது வேற விஷயம். பட் நீங்கள் இப்போ இது எலிவேட் பண்ணிருக்கீங்க. இது சல்குலர்மா? இன்டர்னல் பெவலிங் வந்து 1 to 2 mm from the gingival margin. You have to always keep the brain like this and go according. It's more like a given like a line. Telling me எவ்வளோ இருக்குது டிஷ்யூ லாக் ஆகிடும். இது 2 டிஷ்யூ மட்டும் எடுத்துக்கணும். ஆல்மோஸ்ட் எல்லா
நம்மளோட வாயில் டிஷ்யூ டேர் பண்ணிக்கிறாங்க. ஹோலாகவே அந்த எவ்வளோ டேர் பண்ணாமல் சிங்கிள் இப்போ உடச்சிட்டா உடைக்க வேணாம், அப்படியே பண்ணலாம். நம்ம உள்ளே பண்ணும்போது எப்படின்னா உள்ளே பண்ணும்போது எப்படின்னா ஆங்கிள் ஷுட் பி ப்ளீஸ் லைக் திஸ். உங்களுக்கு போன் ஹிட் ஆகிறது ஃபீல் ஆகுது. இதில் வந்து இவ்வளோ தான் தெரியுது. பேஷன்ஸில் போன் ஹிட் ஆகுது.
அதுக்கு பார்த்தா நீங்கள் எக்ஸாம்பிள் இருக்கும். ஒரு எக்ஸாம்பிள் வந்து ஒரு 1 to 2 mm மேலே தள்ளி போகணும். ஸோ இப்படி ஃபேஸ் ரைட் இப்படி தான் போடணும். நீங்கள் இப்படி வச்சுருக்கீங்க. ரொம்ப அவே போகிறீங்க. அப்புறம் உள்ளே வாங்க அப்படின்னு வெரி குட். அப்படியே வாங்க. No going கையை வெளியே நோட்ஸ் இப்போ டெஸ்ட் internal is still challenging initially. Circular is very easy to do.
leading points induce curvature follow பண்ணி leading points induce பண்ணுவோம். இதுதான் இதோட curvature. induce பண்ணிட்டு இப்போ உங்களோட blade வந்து அந்த பாயிண்ட்ஸை ஃபாலோ பண்ணி வரும்.